without further ado, I'll introduce the folks that you're really here to see. And that's Doctors Alison, Callahan, and Nikesh. And I am going to not try to say his name because I now forgot how to pronounce it. Nikesh. Sorry. Let me just do some quick bios. And so Nikesh Kotecha, I think I get that right, is Director of Data Science at Stanford Health Care. He's super passionate about tackling problems in healthcare with technology, using AI and machine learning, right? So that's his bread and butter, and really looking at methods to support clinical decision support and patient care. He has his PhD in biomedical informatics from Stanford, has a breadth of experience leading interdisciplinary teams, including co-founding and running an analytics company around single-cell proteomics and cytometry. He's also an adjunct faculty at Stanford and is closely involved with the Stanford StartX Accelerator. So excited to have him come chat to us about some of the new work he's doing, and I won't spoil it, let him talk a little bit about that. And then Dr. Alison Callahan is an instructor in the Center for Biomedical Informatics Research in our School of Medicine. She's a clinical data scientist at Stanford Health Care Data Science team led by Nigam Shah. She received her PhD from Carleton University and completed her postdoc training here at Stanford. Current research uses informatics to expand and improve the data available in pregnancy and birth. And she's been really looking at developing and maintaining EHR-derived obstetric database. So as such, she's also the co-leader in the Odyssey Perinatal and Reproductive Health, affectionately named PREG, working group. And we're going to hear more about that in a talk that she has tomorrow. And then as part of our SHC data science team, her work focuses on developing and implementing methods to assess and identify high-value apps for machine learning in healthcare settings. So without further ado, I'll turn it over to them. Thank you.
Thank you. That was great intro. I'm going to share screen. Hopefully you all can see that now, and hand it off to Nikesh to begin our session this morning.
So good morning, everyone. Thank you very much for joining, and thanks, Todd, for the intro. You got the name right. And again, super excited and interested to hear from everyone today as well. So Alison and I both are around. You've probably seen us one way or the other. So please, reach out, whether in person or emails, etc. So the goal today was kind of give you guys an update on our data science efforts at SHC. I believe you've had Nigam come and do this last year when he was starting up in his new role as chief data scientist. And hopefully this serves as kind of like a maturation of both in terms of some of the processes and the thoughts that he was having and how we're actualizing some of that work. As partly being a Stanford alum, I'm really excited about STARR and everything that goes on. I think what I've said to people here is like, I remember when Stride was being built and we would talk about how to build Stride. And now in classes, when we teach them how to use STARR to really do data-driven medicine. And so that's super exciting to see. So let's go ahead and go to the next slide. Again, goal here is I'm going to talk briefly, then let Alison kind of really tell you some more specifics around how we're using STARR for our FURM process. And then if there's time, we'll open it up for some questions and discussion as we go along. So next slide. So Todd gave you a very good aspect of what's happening from a research technology perspective. I just kind of wanted to give you one slide on kind of how everything else fits in. So as you guys know, Stanford Medicine is our big umbrella where we really have, 3 cornerstones of the mission, right? So there's the education component, there's do cutting edge research, and then there's also run a health system. And, you guys have heard lots about the education and research in terms of the health system. The current setup that's there is, we're all fall under the technology and digital solutions umbrella. We think a lot about all these entities you see here on your left. We also work closely with children's, just kind of there's the children's group has its own IT department, partly process, partly regulations, etc. But that's kind of like when we think about TDS and how we think about getting workflows into the health system, we're really thinking about SHC, which includes both the hospital here as well as Tri-Valley and our partners as we go along. So next slide. I think everyone has heard AI in some form or another, probably this morning, probably in the last 10 minutes. So I don't need to kind of go into there. One of the things that we keep thinking a lot about, and especially, Nigam has drilled this in very much, is really it's not just about the technology or the model when you think about clinical workflows or even really any kind of workflows. And so whenever we're thinking about our work, we really keep three things in mind. What is the model or the technology? What is the intervention that we're going to do or the action we will do based on the result of the model? And how does this fit into the workflow, right? If we put something in as the 10th thing a nurse is doing, there really is going to be no capacity for that person to do anything. So even if it's the perfect thing, it may never happen. So all three things have to really come together for us to be able to do the work that's needed and implement into the clinical workflow. And so we'll talk a little bit more about that in a little bit. So next slide. So the questions that we really thought through over this last year or so is you can just go through them all. It is really saying, okay, as we think about this piece. So one thing that I think the STARR community has been amazing at and doing really well is just showing the types of advances and opportunities there are through research in improving health. So the question becomes, how do we take those types of opportunities and actually get them implemented into the clinic? And so as we think through that, we thought through about these questions. What people and roles are crucial to help us do that? How do we identify and articulate what's needed in the field? How do we assess what's promising, right? Out of the 100 things we may see in research, realistically, we may be only able to get to 5 to 10. So how do we figure out what those are? And how do we do that using the data that we can collect and we already know, right? So how do we use data to inform these assessments? Out of the 5 or 10 that we could do, what do we need in terms of platform and infrastructure to enable its work? And then how do we align this so that it's aligned with the priorities at Stanford Health Care and there's governance in place? So those are the overarching questions that we were going through. So in terms of people, the way we've structured ourselves is we call ourselves the data science team at SHC. You see that here on the left. Some of us sit under Anurang Revri, who you saw in that slide that Todd was showing earlier, and some sit under Nigam. And we're a mix of people that are data scientists, engineers, clinicians, ethicists, graduate students. And our goal is to really align on what the SHC priorities are, inform some of this field, and then work closely with the folks on the right, which we call the extended AI team, which include folks from research, include folks from imaging, include our cloud infrastructure teams, to really make sure that what's being built is not only useful for the things that we'll need to do, but helps with the work that they're doing as well. And finally, what we may build might be a model, but the end use point is going to be, an interface into Epic, for example. So our inpatient team has to be involved as we think through this. And then sitting on top of all of this is what we call the Data Science Executive Committee. And they are folks at the C level, chaired by Mike Pfeffer, who really are in looking at the work we're doing, approving the projects we would take on as a team, as well as informing the priorities that are going to be needed across the enterprise. So, so we're not just doing things in isolation or within one disease area sometimes, but we're really getting alignment across the variety of different units, which then allows us to operationalize as we go on. Okay, next slide. So how do we structure our work? We structure our work into 4 buckets. There's a bucket around thought leadership and presence. There's a work around assessing whether an AI-guided work will be useful. We'll call FURM assessments, which we'll talk about in a little bit. We certainly have to build infrastructure to do this. And then working with the executive committee, we kind of identify and execute on 3 to 5 projects that have been deemed to have enterprise value. So next slide. You can just go through this. So again, towards this, again, we all are super excited whenever we're teaching now because we can teach data-driven medicine, again, largely enabled by STARR. There's certainly research that you're going to hear about through a variety of the talks at this conference, talking about some of the research that's going on. And certainly, we've been trying to get the word out about, what should be considered both in terms of an evaluation as well as regulation for AI and health systems. And there's a variety of links both on our websites as well as on the HI website. So feel free to check this out. Next one. The one sentence on what a FURM assessment is, it's really to help us articulate the value of a model-guided decision-specific workflow. And this is work you guys have probably seen in one form or another, because a lot of the work has been done at Stanford with Nigam and others. And there's over 20 papers published. So it's a way to kind of try and say, okay, how do we take all this great body of work and get it into a streamlined process that we can, implement across the enterprise? And so we'll talk a little bit about that in a second. To Todd's point of like, we have everything for intake. I'd say on the cloud side, we have everything for clouds. I'm not, my challenge isn't dealing with one cloud. My challenge is dealing with all clouds. So for example, our research IT infrastructure sits on GCP. Our analytics is on an Azure and on-prem hybrid. Our imaging data is kind of similar. We're using Databricks for AI ops, and our integration layer is MuleSoft, which is on AWS. So it's a fun challenge and a different talk, but happy to kind of talk you through how we're doing. We've been doing pretty well in terms of getting a platform up and running, and we should have our first model in production in a couple of weeks. So super excited about that. Next slide. And then finally, just in terms of the executive committee, you can see here who we bring to the table to make sure that we're aligned. And this group of folks are really there both for ensuring governance, but also ensuring that what we take on in terms of the work this group does is of enterprise value. But our goal also is that the infrastructure we're building is helpful for everyone else. Our joke here is that the biggest challenge is trying to get all of these people in a room. That takes its own AI. But it's been happening and they're coming, and we're super excited about all the work that's going on. Right, next slide. And I think this is where I hand off to Alison, and she'll really focus on that second pillar and tell us more what's going on. Thanks.
Yeah, thank you, Nikesh. That was a really awesome overview of sort of the work as a whole that the data science team at SHC does. And for the rest of our time, we're going to focus specifically on this pillar, the second area of activity that we, our shorthand, call FURM, which stands for Fair, Useful, and Reliable Models, or Fair, Useful, and Reliable Models with Monetary Value. And so this process is our encapsulation of the three components of a successful AI-guided workflow that is a model which is designed to predict or classify for some outcome or characteristic, policy, and the capacity of the team who would take a specific action in response to the output of that model. So those are the three components that together comprise a AI-guided workflow. We identified that there are many components to such a workflow that should be evaluated even before a model is necessarily developed, and certainly before it's implemented, in order to identify cases that will be more likely to succeed or less likely to succeed. And so that's what the goal of the FURM process is. We pointed that there are, 23 plus papers. I think it's something like 23 papers and 6 blog posts that led us to this view of the process of evaluating AI-guided workflows, and we encapsulate that as FURM. The process of a FURM assessment, we've broken up into 3 components, which are summarized in this rather busy figure. But in brief, we try to assess for people who come to us with an idea of, I think this kind of machine learning model would be useful here. For those kinds of potential use cases, we try to evaluate sort of what and why. So what is the need that would be solved by a given ML model? And why is it valuable, and why is it needed? Then we propose to identify how to go about implementing an ML model that is beyond just the model itself, as Nikesh pointed out to us earlier. That includes information or components that are built on the technology to get the data in time to make a prediction or a classification, the process by which we will get that prediction or classification in front of the people that need to see it, and then how do those people and when do those people take action, and do they have the capacity for that action? And then a third tranche of our FURM assessments in the future is, how do we tell whether or not it's working? We've done all of the steps to implement this model, design a clinical workflow around it, put it in front of providers or administrators or maybe even patients? How do we tell if it's having the impact that we want it to have? All of these are important concepts and things to measure that we want to encapsulate in the FURM process. But for now, today, we're going to talk about where we've focused our effort thus far, which is on this initial part, because we see this as an important funnel for going from the 10 or 100 potential use cases that might be presented to us down to a smaller number that would move ahead and be implemented at SHC. So there are three types of use cases that we currently support in this FURM assessment process. Projects ideated from School of Medicine faculty, projects identified when SHC wants to partner with a specific vendor. And then we have a third tranche that we call needs finding or enterprise need, where we talk to people in leadership positions and who they work with in SHC to identify current problems that they believe would really benefit from potentially an AI or ML model guided solution. We then have a process for this what and why component of FURM, and I'm going to talk about that now, and specifically some of the data and tools that we use, largely drawn from the STARR system to support that work. So our input here for this what and why process are information about a machine learning model, what action or intervention would be taken based on the output of that model, and the workflow, as in who will take that action, who will share a given piece of information and when. And we surface all of that information through interviews with the team that comes to us with that question and people that they work with or who would be actually implementing that clinical workflow in practice. And we identify all of those stakeholders in an initial intake session that happens with the data science team and the requesting team. And then we output a report, a summary, it's, 4 to 6 pages that summarizes what they told us about the problem, the model, the intervention, and the workflow. So basically recapitulating back to them what we understand the problem to be to make sure that there's no loss of information there. And then also a quantitative assessment of the utility gained potentially by integrating that model into a given clinical or operational workflow. We have a tool called A+ that simulates workflows given information about the patient population, if it's a patient-facing or clinician-facing workflow, and the capacity of the team that would take action. We include a financial analysis given SHC's patient mix. So if this is a workflow that would be designed to modify care or impact care for patients with cancer of a specific type, we would assess how many patients with that kind of cancer do we typically see at SHC in a given year, and base financial analyses off of that information. And then often, most important, but often underlooked, is the ethical and legal considerations that are relevant to implementing a machine learning model or AI system into a clinical workflow. And so we have a team of ethicists and legal scholars who contribute to this part of our assessment. We try to turn this around in 6 weeks. Often a limiting factor here is scheduling the sessions to have the conversations that we need with the requesting team and their colleagues to get the information that we need. STARR OMOP and ACE, the Advanced Cohort Engine, have been part of this process from the beginning. We actually use the data in STARR OMOP to identify how many patients in our historical data meet the criteria for entry into the workflow, how many patients experience the potential outcomes of that workflow, if it's take action or not, and what is the demographic breakdown of those patients, because that's very important to be able to identify potential sources of bias or differential impact based on the patients who have the characteristics of relevance to the problem. And so it was really exciting for us to be able to leverage STARR data and ACE already as the tools to use in this FURM assessment process. I mentioned A+. I won't go into depth on it now because of time, but this is a paper that we published in JBI, Journal of Biomedical Informatics, A+ takes as input a set of predictions or classifications from a model executed over a patient database like STARR OMOP, as well as characteristics of the workflow to essentially simulate how many model predictions could be acted upon given the capacity of the team to take those actions. And from that information, what is the possible utility that could be achieved by executing this workflow? I think Nikesh mentioned, if we are adding a 10th activity to a nurse's workflow of 9 things, such that that 10th activity can never possibly happen in a day, even if we have the most excellently performing model, the utility of that model will be 0 because no one will be able to take action. And so A+ helps us to identify those sorts of constraints and identify potential solutions by modifying things like personnel or workflow. Ethical considerations, the process here in a nutshell, we aim to identify value mismatches between different types of stakeholders that are involved in the decision to implement an ML-guided workflow. We know that vendors and providers and patients might have very different views on the same piece of data that could be informing the care for that patient. And we hypothesize that those views, if there are conflicts or differences amongst them, will help us to identify very important ethical considerations that should be taken into account or at least be made aware of when making the decision to implement an ML workflow in practice. And lastly, financial projections, very helpful to the system often in making a go or no-go decision in terms of not only cost of implementing and deploying a model, which we have a fairly good handle on, but also staffing people to take action on that workflow and cost or benefit of potential downstream patient impact and how that might affect the health system. We've completed this process for 5 use cases so far. We've given a report that looks like this. Here is the front page of one of those reports. We've given that back to 5 teams. The cases that we've managed are listed on the right here, related to peripheral artery disease screening, coronary calcium scoring for CVD risk, STEMI screening in the ED, acute care use for chemotherapy patients, and then a very interesting operational use case around improving documentation and coding for inpatient care. I won't go into this, but this is just an example of what some components of the report look like. And again, just to say that for us, I think what's really relevant here for this group are the value of STARR data and tools for this purpose. We use STARR data to estimate patient volume for workflow capacity in our workflow simulations, how many patients experience outcomes relevant for our financial projections, and again, that patient demographic breakdown information, which is highly relevant for identifying ethical considerations for the team. These are just some of the people behind the work. I was even adding names to this at the end of the night last night, and so that's why the sum of, if your name isn't here, but you are part of this team, thank you. We acknowledge this is an excellent and diverse and growing group, and we are continuing to grow. So if you're interested in talking to us more about that, you can email us, as Nikesh said, but also hopefully we have a few moments for questions or discussion if some questions have popped up in the Q&A. Thank you so much. You're muted, Priya.
Yes, we definitely have time for some questions. Users can also raise their hand. Attendees can raise their hands, and if they have a question, or you can post a question in the Q&A.
Is there anything I missed, Nikesh, that you want to go back to?
So I had a question, which is, could you maybe walk us through one of your use cases that you've actually created a report for? I mean, I don't know if you can talk about it, but like a sample case that, this is how I would look at, this is what is presented, but this is how I would view it from, say, the ethical lens. This is what I would, this is what would come out of the financial implications. Can you walk us through one of them?
Yeah, maybe we can talk a little bit about the Elsie's case with the PAD. So, we will have people come to us, so Elsie Ross being one of them, who has done some pretty interesting work around peripheral artery disease. There's a model that can really help us, kind of increase value and care on that side. So one of the first things we do is we'll have her come talk to us. We'll elicit a workflow. We'll elicit what the changes could be. And then, as Alison pointed out, part of the goal is to understand what is the patient population this would affect. How does the workflow at a high level look? And then some of the work we would do kind of using those assumptions is trying to understand, okay, how many of these types of patients have we seen over the last 3 or 4 years? What do we expect happening downstream? And then the ethical lens is really, it's not there to stop anything, but really to kind of say, have you thought about these things, right? So one of the classic ones that we come up with Stanford population is it's not diverse enough. So, let's make sure that we've highlighted that. Have we thought about how to do something about it? Do we know what that means? Or, we have some processes in place where, again, it may make sense for the Stanford health system, or may not make sense for the Stanford health system, but may make sense for another health system, for example, right? So those are the types of things we try and elicit, along with then also trying to understand downstream implications, right? So, for example, if it's going to cost us, $500,000 to put a model in, but the patient population is such that we could hire a full-time person and they can take care of it, does it make sense to put the model in versus having a full-time person, right? Those are some of the objective things that we can try and get to through some of the analysis we do. And Alison, please add.
I think you hit all of the points really well. And, in the case of Elsie, this was an example of a faculty ideated use case. Elsie is a vascular surgeon, and she identified that many patients with PAD, and this is a known issue, are undiagnosed, as in they have peripheral artery disease and there's a known diagnostic test for it, but the right people are not being given that test. And so her hypothesis was that a classification model running on something like STARR OMOP, which could identify patients that should have that diagnostic test, would increase the number of patients that are diagnosed earlier in their disease course, and then that would benefit from earlier and less intensive intervention, maybe even avoiding surgery altogether. And so when she came to us with this use case, we walked through a conversation about, well, what does it look like when you identify someone with peripheral artery disease? What possible actions do you take for them? And she identified sometimes it's medication, sometimes it's surgery, sometimes it's watching. And so we were able to simulate those possible workflows, given information about the capacity of her team and the number of patients that we see at Stanford that would even qualify for entry into that workflow, to estimate sort of how many patients do you have the capacity to manage and what would that look like. And so that was an example, and that has gone in front of the executive committee as well and been part of their assessment. So it's sort of an end-to-end use case that we have been able to work through.
Yeah, so I'd say one of the things we're trying to get our heads around is, so our goal is to be helpful. So we're trying to kind of provide additional information that, we would be doing anyway to take anything we would take to the executive committee. But we think this would be useful to the SHC community at large. And so if they come to us, we'll help do this assessment, we'll give it back to them, and we hope that informs anything else downstream that happens, whether or not we're involved or not. And whether it is, okay, more research needs to happen, this will be useful to, for other teams to assess as well, those types of things. And so, right now, a big challenge at SHC, as I'm sure you guys know, is there's a lot of things coming and everyone's using data science and AI in some form or another. And so, what's a framework that, we could put out there to help everyone kind of at least ask some of these questions? Not all of these questions make sense to ask. Not all of them should be asked, but, what can we provide as a service that would be useful broadly? And we're going to do the same thing for anything we take to the exec committee for them to approve for us to do.
So basically, the researcher, once they validated the model, say in their lab, they come to you, they put their case in front of you, you would go through this FURM assessment, And then you would decide whether or not it moves up to the executive committee. And if they approve it, it is actually going to be beta tested or whatever at SHC. Is that what that means, or what does it mean?
Yeah, so again, all of this is new process. So so they would come to us, like I said, we'll help do this assessment. We would give it back to them to use as needed. We would also include it in anything we're showing to the exec committee as part of the assessments. So again, out of that, the exec committee may say it's useful for our group to take it on from an enterprise-wide problem, or they could say this is very useful, but there's another group that should take it on and they should go. And then anything that we take on, the goal is that because the exec committee has blessing, my fingers are crossed that it helps me with trying to get resourcing and priority to kind of get it in play, right? So it's still a process to take anything from implementation into workflows and into the pieces. We have to still get that entire extended AI team on board with things we're doing. So
makes sense. So are there any other questions? So if there aren't any other questions, thank you, Nikesh and Alison, for that really insightful presentation. I'm going to hand it over to Sanjay now and he's going to host the next session.
thanks,
Thank
guys.
you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.